ENN for inviting us. It's a real pleasure to be here. Actually, it feels a bit like being back in a family. There's so many familiar faces. It's wonderful. We're going to present to you, it's a bit of a gallop actually because we've got just 15 minutes overall, some of the key findings that have come out of a review that the ENN undertook into current global and country level financing arrangements for CMAM. And what we're going to do is just summarise a few of the key points, certainly not all of them. But I want to point out that in the room, or at the back of the room, the main findings from this work that we undertook mid-last year through to the first quarter of this year is in this ODI network paper. It's not a plug, but if you do want to read it, you're very welcome. I think there are 100 or so copies available in the room. So please feel free. So why did we carry out this review? Anne mentioned, Anne from DFID just now, the CMAM conference in Addis Ababa. This was co-hosted by the ENN with the government of Ethiopia, and it was very much focused on the perspectives of governments in scaling up CMAM. Actually, I think it's fair to say we don't always hear government voice about their experiences. So this was a real opportunity. One of the recurring issues raised at that CMAM conference, I know a lot of you were there, remember this, was the whole issue of how do we do the financing? How do we sustain the levels of financing required to treat while we get on top of preventing? So we undertook the review, carrying out, as typically in these sorts of reviews, case studies, interviewing key informants, and so on and so forth. So before I get on to some of the findings from that, I just want to emphasize three things, and they've already been raised a little bit this morning. I think we should be proud of the achievements we've made so far with CMAM. I think the fact that it's in 60 plus countries is quite an achievement, and I don't think we should feel too depressed here over the next couple of days. Of course, the biggest burden's Asia. It's 70% of the acute malnutrition burden. They've got a long way to go, but let's just imagine what will be achieved in treatment coverage when Asia comes on tap and starts to really embrace treatment, as it surely will. So there's a lot achieved, but still a lot further to go. And the point here is that the discussion around financing is a critical aspect of that. It's not just the technical detail, it is how we're going to put in place the necessary finances. Of course, we all know CMAM is cost effective, it's the SAM treatment component at least. The issue here is the per capita cost. Now, we've just heard that in Kenya, for DFID, they've just found out that the multi-year funding that's in place there actually represents the bulk of nutrition financing in Kenya. That really speaks volumes for the problem that we've been thinking about during the review that we undertook, that for many governments, their domestic allocations for nutrition are so low. And Kenya, I would argue, is one of the most committed countries to CMAM treatment and to nutrition generally. And yet the Treasury is allocating very little to nutrition at the current time. So, you know, if you think about just SAM treatment in startup cost, you're talking about anywhere between $150 and $200 per child in startup. Obviously, CMAM gets cheaper when you get beyond those initial capital costs and so on. But it is a lot of money when you aggregate that to burdens at country level. And just to mention, and I'm sure this will come up quite a bit in the next 2 days, 50% and more of that cost is occupied by RUTF. And within that, the cost of dried skim milk and some of the micronutrient vitamins required in that remedy. So, as Steve said earlier, we had all hoped, hadn't we, that many countries would be taking on to scale production. And to be fair, that hasn't really happened. We call it in our report a production red herring because it isn't what happened. Malawi is an exception. It's done incredibly well. Ethiopia is also doing well. There are other countries, but it hasn't dramatically lowered the cost of CMAM. At best, maybe around 20% overall. So there's a lot more to do, and I'm hoping we're going to hear a bit more about these alternative formulations and the cost issues to do with that over the next couple of days. I just wanted to highlight for you, just taking a couple of countries so that it's in our minds as we have these conversations. If you just take Kenya, 2011, treating 67,000 children, this is in the Assals area, which are emergency prone, as many of you are. That's 6.4 million, that bill, to treat. This is SAM and MAM combined. In Ethiopia, to get to 300,000 SAM cases, it was 21.5 million. So these are really significant costs. And both of these countries are ambitious around their targets in the next 2 to 3 years. They really are ambitious. And so this bill goes up and up and up. Where is this money coming from? How do we sustain it? So just coming on then to what we found about the current CMAM environment, the current financing environment. I just want to make 4 points. How am I doing? Very well. Good. This is a gallop. And the first point is that, and it's not going to surprise you because we've been hearing that from some of the other presentations, the mainstay of CMAM financing is humanitarian pots of money. That is the case today. And, you know, we can understand that to some degree because CMAM was born out of response to crisis situations. But 10 years on, is that really where we want to see things at the moment? I think not. But I think the other feature of why CMAM is so dependent on short-term humanitarian financing is this divide between how wasting is understood. It's been traditionally seen as an emergency intervention. We wait for thresholds, then the money kicks in and CMAM's introduced. Whereas on the other side of that, stunting is very much more seen as a development concern. So we have real divides in the way that we're conceiving of the problem of undernutrition, the way in which our financing is organised, the way in which we respond. And I think in this next 2 days, if we can talk more about how we break these barriers down, we really will hopefully move things on a bit. So one of the recurring comments made to Jeremy and I, and Lola, who was involved in this review, was we need to position acute malnutrition as a development concern. And I think Andre very clearly set out in his presentation earlier, we really haven't done that. The conversation is stunting. We're not having that conversation with acute malnutrition. And I don't know how many development practitioners there are in this room. That would be interesting to have a conversation about. Secondly, the fact that CMAM is so dependent still on short-term windows. It is short-term and it makes it unpredictable. And that brings with it a whole subset of challenges. So many challenges, I'm not going to try to go through them all now, but we heard about stop-start of programming. And that has real knock-on if we're going to really build resilience, nutrition resilience in these countries. It's very hard for governments to plan. It's very hard for agencies supporting governments to plan around unpredictable financing. It's very hard to integrate. Steve was saying we need to really build the community. But actually, from our review, we found that the community element is one of the hardest things to fundraise for. So, you know, we're really missing a big point here. There's a real shortage of funds to do that community work. And somebody said from UNICEF in one of the regions, the biggest threat to CMAM scale-up is the nature of short-term funding, and I think probably we'd agree that that is the case. The third point, very little funding goes through governments. I don't know if this is particular to CMAM and nutrition generally, but even from development pots of money, rarely do you see resources being allocated through budget support to governments or through other facilities. Now, there are many reasons for that, and we don't need to go into that right now, but what is the knock-on effect of this? And one of the observations we had that people highlighted for us, oops, I'm running over time, is that this may be actually reducing the level of government felt ownership. That then has a knock-on to Treasury and budget allocations. You know, you haven't got government people arguing Treasury for more resources because they're seeing it as external to them, as donor-driven, as agency-driven. And then finally, we've already heard, there's little allocation by governments to CMAM. There are examples, and at best these cover maybe 10, 20% of the cost, but overall it is quite small. And that needs to be discussed over these couple of days. So with that in mind, if we're going to get away from the current level of coverage or treatment to maybe at best 10% and build that up to 30, 50, even 80% over the... How are we going to do it? And with that, I'm going to ask Jeremy to give us all the answers now. Thank you.
Ways forward, just a few suggestions from us. First of all, there clearly needs to be a paradigm shift in thinking about acute malnutrition, no longer just being seen as a humanitarian concern. No longer being seen as a humanitarian concern. Development actors need to step up. There also needs to be more work on the relationship between wasting and stunting, because that could be very useful in advocacy terms. We were surprised how little vision there is out there around scaling up CMAM and sustaining scaling up, talking to donors, the UN agencies, the INGOs implementing these programs. No one could really tell us how this was going to remain at this level and increase in a sustainable way. So there needs to be more of a vision about financing of CMAM scale up. The stop-start approach isn't going to work, clearly. That vision needs to be country-specific, and it needs to be based on robust national costing exercises. And I think for each country there needs to be careful consideration to the financing mechanism which is going to work best, and as alluded to by Carmel, that will actually strengthen nutrition governance in that country. In other words, encourage government, the Treasury, to invest more and more in nutrition rather than looking to the external donor community to fund those programs. The costing exercises happening under Sun at the moment are a positive development. Excuse me. Carmel talked about the shortcomings of the humanitarian funding, the stop-starting, the types of activities which are hard to fund. We heard from DFID before us how DFID are now using multi-year funding. We think this is a very positive development. They're also, as in the case of DFID Yemen, combining humanitarian and development funding, which is clearly appropriate given that acute malnutrition is not just a humanitarian problem. The trouble is, and again this was alluded to by Abby, is that not all donors, we suspect, are as flexible as DFID. On the state side, you've got USAID and OFDA, who barely speak to each other. You've got ECHO and the EC, and in CEDA there's also strong divisions between humanitarian and development sections. That's going to be a problem. I'll return to that in a minute if I've got time. Carmel alluded to the fact that we need to put much more funding through governments now, pooled funding, budget support, match funding, whatever. Issues around the sort of impediments that donors worry about, transparency and accountability, we think can be gotten round. There are many, many examples of highly fragile states where pooled funding has worked for the health sector. Why not for nutrition? What we need are clear MOUs on national financing visions between donors and governments, and they need to set out incremental support from government, incremental support from government as donor funding is slowly withdrawn. But that donor funding, we feel, has to increasingly go through government, otherwise you're not supporting nutrition governance. Two other points. This wasn't mentioned by Carmel, but it's very, very evident in the report, and I think Diane Holland alluded to it a little bit, is that one of the things that shocked us was how currently acute malnutrition is dealt with by three agencies, UNICEF, WHO, and WFP, dealing with different bits of the same problem, really. What we found on the ground is that this does not encourage coherent programming, and we feel there is a need to really look at this, the way acute malnutrition is divided up between the UN, and also to examine what may be very high economic transaction costs as a result of that. And finally, again, I think Abby alluded to this in her excellent presentation, that wouldn't it be great if there was more of a forum, a technical forum for donors to actually discuss what they're doing, how they're financing nutrition, and to learn from each other about how different financing mechanisms impact nutrition programming on the ground and nutrition governance. Because, my God, I think there's a lot to learn from each other here, not least of all the difficulties that some donors have and the way other donors have gotten around those difficulties. Thank you.